Good day, everyone. It's really a pleasure to be part of this workshop today and share a few thoughts about how we optimize treatment in adolescents living with HIV. And we need to start by acknowledging that treating HIV in adolescents comes with challenges. We know that adolescents are less likely to be virologically suppressed, and if vertically infected, often present acquired HIV drug resistance from their mother. We also know that they're more likely to fail first line with multi-drug resistance, and that limits the treatment options, and which is obviously very difficult in the context of lifelong treatment. So we need to start treatment with the best drugs. We need to be able to identify virological failure, and we need to be able to switch to second line as quickly as possible so that we can minimize selection of drug resistance and really optimize the future for treatment options for these populations and really overall improve clinical outcomes. Now, we know that starting with the best drug today means starting with TLD. And it's great to see that after a number of clinical trials that supported the superiority of the dolutegravir-based regimen over the standard of care, we now have actually programmatic data that confirm that dolutegravir-based regimen are very well tolerated and they are very effective. And as you can see, that's not just on those that were already suppressed in the pink circle, but also in those that were not suppressed before starting the dolutegravir, then were able to reach virological suppression after that in the green circle. Now, we know that no drug is perfect, and there's been concern about weight gain in adults that started to use dolutegravir. Now, these same cohorts from the Baylor group presented at the PEDS workshop data that suggests that there is indeed significant weight increase in adolescents, but they also noted that a very large proportion of their adolescents was underweight, and 2 out of 3 were able to reach weight gain after starting dolutegravir. Overall, they do recommend, though, that weight monitoring with appropriate dietary and lifestyle changes is implemented when treatment is provided to adolescents living with HIV. Now, these findings are partly aligned with what was presented at the same conference by the Odyssey trial that showed that when you compare the dolutegravir-based regimen with the standard of care, there is indeed difference in the weight gain, but the differences only occurred early, and the gap between the two arms did not increase over time. So it really does appear that the weight gain in adolescents is not as significant as in adults, and so definitely reassuring, but important to continue monitoring. We also know that it's not just about the ARVs. We must not forget preventing and treating advanced HIV disease for those adolescents that present late or those that disengage from care and then come back. TB, cryptococcal disease are really critical diseases that we should be able to identify, treat, and prevent where possible. We also know the package of care needs to include mental health interventions. Mental health is a priority for adolescents living with HIV, and we now have a strong recommendation that supports psychosocial interventions in this group because we can improve adherence to ART and therefore reach virological suppression. All of this fits very well peer-driven model and the integration with the existing package of services, and overall really helps us to ensure that young people can be put at the lead from the front at the front in implementing adolescent services, and they've really been a great part of developing this same recommendation last year. So what's on the horizon? Well, we know that there is more discussions around potentially moving away from oral dairy therapy. We might have oral regimens that are used less frequently, implants, injections, patches. So a lot of new technologies are being considered to deliver new ARVs. We know there is a study that is ongoing, the MOCA study, that is exploring the use of cabotegravir injectable in adolescents living with HIV. We know that this is unlikely to be scaled globally, but we know this is an important proof of concept to inform the investigation of new molecules that are currently being considered that come from different classes and in that sense that are very suitable to be administered to even those that are affected by a high degree of HIV drug resistance with previous regimens. So it's really important that we enroll adolescents in these trials and that we fully understand what are the characteristics of these technologies and drugs that make these regimens more acceptable and more desirable for adolescents. So to conclude, I think it's clear that optimizing treatment for adolescents today means using the best drug, dolutegravir, providing more than just the ARVs, but also treat and prevent advanced HIV disease and provide a more comprehensive package of care, which also helps with dealing with toxicity that result from the drugs we're using, but also that provides psychosocial support to really be able to stay virologically suppressed through the rough patches. And all of that with the usual and important adoption of adolescent health-friendly services. What will mean optimizing treatment tomorrow, we don't know yet, but we hope it will be about less drugs administered less frequently with really good technologies. And to do that, we need to make sure that your voice of adolescents and young people living with HIV is heard, and that you are included in studies that really helped us to generate the data that we need to be able to take these drugs to you all much faster than before. So I'll stop there, and thank you very much for your attention.